Medical coding is the transformation of healthcare diagnoses, procedures, medical services, and equipment into universal medical alphanumeric codes. In podiatry, this process is fundamental for accurate billing and reimbursement. It involves translating detailed clinical documentation into standardized codes that payers, like insurance companies and government programs, can understand and process. Proper coding ensures that podiatrists are fairly compensated for the services they provide to patients. It also plays a crucial role in data collection for health statistics, research, and healthcare planning, reflecting the prevalence and treatment of various foot and ankle conditions within the population. Without precise coding, the financial health of a podiatry practice can be significantly compromised, leading to payment delays or denials. The importance of accurate coding in podiatry cannot be overstated. Each patient encounter generates a wealth of information that must be meticulously documented by the healthcare provider. This documentation serves as the primary source for selecting appropriate codes. Coders must possess a strong understanding of medical terminology specific to podiatry, anatomy of the lower extremities, and the nuances of various foot and ankle disorders. They must also stay updated with constantly evolving coding guidelines and payer policies. This ensures that the services rendered are represented truthfully and accurately, supporting medical necessity and compliance with regulatory requirements. Diligent coding practices help prevent audits and potential penalties associated with improper billing, safeguarding the practice's integrity. Podiatry practices utilize three main code sets: Current Procedural Terminology, CPT, International Classification of Diseases, 10th Revision, Clinical Modification, ICD-10-CM, and the Healthcare Common Procedure Coding System, HCPCS Level 2. CPT codes describe medical, surgical, and diagnostic services performed by physicians. ICD-10-CM codes are used to classify and code all diagnoses, symptoms, and reasons for encounter. HCPCS Level 2 codes report supplies, durable medical equipment, DME, and certain services not covered by CPT. Mastery of these three code sets is essential for any individual responsible for coding in a podiatry setting. Each code set has its own specific rules and conventions that must be followed precisely. Ultimately, effective medical coding in podiatry bridges the gap between clinical care and financial administration. It ensures that the complex services provided by podiatrists, ranging from routine foot care to intricate surgical procedures, are communicated effectively to payers for appropriate reimbursement. This requires a dedicated effort to maintain high levels of accuracy and compliance. Investing in ongoing education and resources for coding staff is critical for the success of any podiatry practice. Accurate coding also contributes to a larger understanding of public health trends related to conditions of the foot and ankle, helping to shape future healthcare policies and resource allocation for these common ailments that can significantly impact a patient's quality of life. Current Procedural Terminology, CPT codes are published and maintained by the American Medical Association, AMA. These codes are used to report medical, surgical, and diagnostic procedures and services. In podiatry, a wide range of CPT codes are utilized, reflecting the diverse services offered from evaluation and management, EM services, to complex surgical interventions on the foot and ankle. Understanding the specific CPT guidelines relevant to podiatry is crucial for accurate billing. This includes knowing how to select the correct EM level based on the complexity of history, examination, and medical decision-making, or based on total time spent on the day of the encounter for certain services. Many podiatric procedures also involve specific CPT codes found in the integumentary system and musculoskeletal system sections of the CPT manual. Modifiers play a significant role in CPT coding for podiatry. Modifiers provide additional information about a service or procedure without changing its definition. For example, modifier 25 is used to indicate that a significant separately identifiable EM service was performed by the same physician on the same day of a procedure or other service. Modifiers like LT, left side, and RT, right side, are essential for specifying laterality for procedures performed on paired anatomical sites, such as the feet. Other commonly used modifiers in podiatry include 59, distinct procedural service, to indicate that a procedure or service was distinct or independent from other non-E/M services performed on the same day. Proper use of modifiers is critical for avoiding claim denials and ensuring appropriate payment. Podiatry-specific CPT codes often cover services like nail debridement, callus removal, incision and drainage of abscesses, and various surgical repairs of tendons, ligaments, and bones of the foot. For instance, codes in the 117XX series are frequently used for nail trimming and debridement. Surgical procedures such as bunionectomies, codes 28292 to 28299, or hammer toe corrections, code 28285, have specific codes that must be chosen based on the exact technique performed by the podiatrist. It is imperative that the operative report and clinical documentation clearly support the CPT code selected. The level of detail in the documentation directly impacts the ability to choose the most accurate and specific CPT code available for the service provided. Furthermore, understanding global surgical package concepts is vital. Many surgical CPT codes include a global period, 0, 10, or 90 days, during which normal, uncomplicated follow-up care related to the surgery is included in the payment for the surgical procedure itself. Coders must be aware of what services are bundled into this global package to avoid unbundling and improper billing. For instance, routine post-operative visits for suture removal or dressing changes related to a major foot surgery are typically included. However, if a patient develops a complication requiring a return to the operating room, this might be separately billable. Adherence to CPT guidelines ensures compliance and supports the revenue cycle of the podiatry practice by minimizing errors. The International Classification of Diseases 10th Revision Clinical Modification ICD-10-CM is used to report diagnoses in all healthcare settings in the United States. For podiatry, accurate ICD-10-CM coding is essential to establish medical necessity for the services rendered. Payers use diagnosis codes to determine if the procedures performed, CPT codes, are appropriate for the patient's condition. ICD-10-CM offers a high level of specificity, allowing podiatrists to describe patient conditions in great detail. This includes codes for common podiatric ailments such as plantar fasciitis, M72-2, ingrown toenails, L60-0, Achilles tendonitis, M76.6-, diabetic foot ulcers, for example L97.4-, L97.5- with associated E10, E13 diabetes codes, and various fractures and injuries of the foot and ankle. Coders must select codes to the highest level of specificity available. Laterality is a key feature of ICD-10-CM, particularly relevant in podiatry. Many codes require specification of whether the condition affects the right side, left side, or is bilateral. For example, a diagnosis of plantar fasciitis would be M72-2 for an unspecified foot, but if the documentation specifies the right foot, then M72.21 would be more appropriate, and M72.22 for the left foot. Failure to include laterality when required can lead to claim rejections. Similarly, the system distinguishes between initial encounters, subsequent encounters, and sequelae for injuries and certain other conditions. This level of detail helps paint a complete picture of the patient's clinical situation and supports the rationale for treatment provided by the podiatrist. Training on these conventions is vital for coding accuracy. ICD-10-CM coding guidelines also provide instructions on sequencing codes. The primary diagnosis, which is the main reason for the patient encounter, should be listed first. Any coexisting conditions, comorbidities, or contributing factors should be listed as secondary diagnoses. For example, if a patient with type 2 diabetes mellitus presents with a foot ulcer, the appropriate diabetes code, for example, E11.621 type 2 diabetes mellitus with foot ulcer, should be listed, followed by the code for the specific foot ulcer, for example, L97.521 non-pressure chronic ulcer of other part of left foot with necrosis of muscle. This linkage is crucial, especially for conditions where systemic diseases manifest in the lower extremities, demonstrating the medical necessity for specialized foot care. Podiatry coders must also be familiar with the use of external cause codes, V00Y99, and Z codes, Z00Z99. External cause codes describe the environmental events, circumstances, and conditions as the cause of injury, poisoning, and other adverse effects. While not always required for reimbursement, they provide valuable data for injury research and prevention. Z codes report reasons for encounters for circumstances other than a disease or injury, such as prophylactic care, for example Z41. 1. Encounter for cosmetic surgery if applicable and not covered, or Z01.818. Encounter for other pre-procedural examination for routine foot care for at-risk patients. Staying current with annual updates to ICD-10-CM codes and guidelines is paramount for maintaining compliance and ensuring accurate diagnostic reporting in podiatric medicine. The Healthcare Common Procedure Coding System, HCPCS, is divided into two principal subsystems, Level 1 and Level 2. Level 1 is the CPT code set. HCPCS Level 2 codes are alphanumeric codes used primarily to identify products, supplies and services not included in the CPT codes. These include ambulance services, durable medical equipment, DME, prosthetics, orthotics, and supplies, DMEPOS, when used outside a physician's office. For podiatry practices, HCPCS Level 2 codes are essential for billing items such as custom-made orthotics, for example, L3000, L3031 series, therapeutic shoes for individuals with diabetes, for example, a 5500A, 5514 series, and various splints, braces, and dressings used in patient care. Podiatrists who dispense DMEPOS items must be familiar with specific HCPCS Level 2 codes and the associated billing rules. For example, code A5500 is for a diabetic shoe, custom molded, while A5501 is for a diabetic shoe, depth inlay. It is crucial to select the code that accurately describes the item provided. Additionally, many HCPCS Level 2 codes require modifiers to provide further specificity. For instance, modifiers KX, requirements specified in the medical policy have been met. Georgia, waiver of liability statement issued as required by payer policy. GY, item or service statutorily excluded or does not meet the definition of any Medicare benefit. And GZ, item or service expected to be denied as not reasonable and necessary, are commonly used with DMEPOS claims, particularly for Medicare. Beyond DMEPOS, certain services specific to podiatry, particularly routine foot care, often involve HCPCS Level 2 codes, especially when billing Medicare. While CPT codes like 11719, trimming of non-dystrophic nails any number, or 11720/11721, debridement of nails by any methods, 1 to 5, 6 or more exist, Medicare has strict coverage guidelines for routine foot care. Services may only be covered if certain systemic conditions are present that make routine care by a non-professional hazardous. Q modifiers, Q7, Q8, Q9, are used with these CPT codes to indicate the presence of such qualifying conditions. For example, Q8, 2 Class B findings. Understanding these nuances is critical for compliance and proper reimbursement when providing these services. Accurate documentation is paramount when billing with HCPCS Level 2 codes. For custom orthotics, the documentation must support the medical necessity and the custom nature of the device. For diabetic shoes, specific criteria regarding the patient's diabetic condition and foot complications must be met and documented. Podiatry practices should maintain detailed records, including physician orders, proof of delivery, and any necessary certifications or advanced beneficiary notices, ABNs. Regular updates to HCPCS Level 2 codes occur, so practices must ensure they are using the most current codes and guidelines. Proper use of these codes ensures that the practice is reimbursed for supplies and specialized services, contributing significantly to the overall financial viability of the podiatric practice. Section 5. The National Correct Coding Initiative, NCCI, and Medicare Edits. The National Correct Coding Initiative, also known as CCI, was developed by the Centers for Medicare and Medicaid Services to promote national correct coding methodologies and to control improper coding leading to inappropriate payment in Medicare Part B claims. NCCI edits consist of pairs of HCPCS or CPT codes, known as procedure-to-procedure edits, that should not typically be reported together for the same patient on the same date of service. One code is designated as Column 1, the payable code, and the other as Column 2, the bundled code. If both are billed, the Column 2 code is generally denied unless a clinically appropriate NCCI-associated modifier is used and supported by documentation. Understanding NCCI PTP edits is crucial for podiatry practices. For example, an EM service might be bundled into a minor surgical procedure performed on the same day, unless the EM service is significant and separately identifiable, reported with modifier 25. Similarly, many surgical procedures have components that are considered integral to the main procedure, and should not be unbundled and billed separately. Podiatry coders must regularly consult the NCCI edit tables, which are updated quarterly by CMS to ensure compliance. The edits specify whether a modifier is allowed to bypass the edit. If the modifier indicator is 0, the code should never be reported together. If it's 1, a modifier may be used if appropriate. A 9 indicates the edit was deleted. In addition to PTP edits, NCCI includes medically unlikely edits or MUEs. MUEs define the maximum units of service that a provider would report for a single beneficiary on a single date of service for a specific HCPCS or CPT code. For instance, there might be an MUE for the number of nail debridements like CPT 11721 that can be billed for a single patient on one day. Billing more than the MUE value for a code will typically result in denial of those units exceeding the MUE. Some MUEs are absolute, while others can be appealed with appropriate documentation. Podiatry practices must be aware of MUEs relevant to the services they provide to avoid automatic denials and ensure accurate claim submission. Medicare policies significantly influence podiatry coding and billing beyond NCCI edits. Local coverage determinations or LCDs and national coverage determinations or NCDs provide specific guidance on whether certain services are considered medically necessary and therefore covered by Medicare. Podiatry services like routine foot care, treatment for plantar warts, or debridement of mycotic nails are often subject to strict LCDs that outline covered diagnoses and frequency limitations. Coders and billers must be intimately familiar with the LCDs applicable in their Medicare administrative contractor jurisdiction. Adherence to NCCI edits and Medicare coverage policies is not just good practice, it is a requirement for compliant billing and avoiding costly audits or recoupments. Section 6. Complex Coding Scenario 1. Comprehensive Diabetic Foot Management. Consider a 68-year-old established male patient with type 2 diabetes mellitus, with peripheral neuropathy and peripheral vascular disease. He presents for a scheduled follow-up visit with a new, painful, full-thickness ulcer on the plantar aspect of his right great toe, measuring 1.5 centimeters by 1.2 centimeters, with surrounding erythema but no exposed bone. The podiatrist performs a problem-focused history and detailed examination of the lower extremities, focusing on vascular status, neurological deficits, and the ulcer characteristics. Medical decision-making is of moderate complexity due to the new problem, the need for prescription drug management, antibiotics considered, and the risk of complications given his comorbidities. The ulcer is then debrided of necrotic tissue down to healthy bleeding tissue using a scalpel. A sterile dressing is applied. For this encounter, the EM service would be reported. Assuming the documentation supports a Level 4 established patient office visit based on moderate MDM or total time, CPT code 99214 could be appropriate. Since a significant, separately identifiable EM service was performed on the same day as a minor procedure, debridement, modifier 25 would be appended to 99214, 99214-25. The debridement of the ulcer, assuming it involves debridement of skin and subcutaneous tissue, would be coded from the 11042 to 11047 series. If the debridement was of skin and subcutaneous tissue for the first 20 square centimeters or less, CPT code 11042, debridement subcutaneous tissue, includes epidermis and dermis if performed. First 20 square centimeters or less would be selected. No laterality modifier is needed for 11042 itself, but the diagnosis will specify laterality. The ICD-10-CM coding requires careful attention to detail. The primary diagnosis linking to the ulcer debridement would be specific to the ulcer. For a diabetic foot ulcer of the right great toe without gangrene but with necrosis of subcutaneous tissue, a code like L97.513, non-pressure chronic ulcer of other part of right foot with necrosis of subcutaneous tissue, might be used. It is crucial to also code the underlying diabetes. E11.621, type 2 diabetes mellitus with foot ulcer, would be reported, followed by codes for the associated complications, E11.40, type 2 diabetes mellitus with diabetic neuropathy, unspecified, or a more specific neuropathy code if documented, and E11.51, type 2 diabetes mellitus with diabetic peripheral angiopathy without gangrene. The order of these codes may vary based on payer preference, but E11.621 often links directly to the ulcer for medical necessity. If any specific supplies were used beyond those typically included in a minor procedure tray, such as a specialized dressing that is separately billable, a HCPCS Level 2 code might also be reported, though this is less common for simple dressings applied in office. The documentation must clearly support the EM service elements, the depth and extent of debridement, and all diagnosed conditions. The podiatrist's notes should detail the appearance of the ulcer, the tissue removed, the condition of the underlying tissue post-debridement, and the patient's overall vascular and neurological status. This comprehensive coding accurately reflects the complexity of managing a diabetic patient with a new foot ulceration, ensuring appropriate reimbursement, and demonstrating the medical necessity of each service. Section 7. Complex Coding Scenario 2. Surgical correction of bunion and hammer toe. A 55-year-old female patient presents with a painful bunion, hallux valgus, of the right foot and a symptomatic rigid hammer toe of the second digit, right foot. Conservative treatments have failed. The podiatric surgeon performs an Austin-type bunionectomy, distal metatarsal osteotomy, on the right first metatarsal. During the same operative session, the surgeon also performs an arthroplasty for correction of the rigid hammer toe on the right second digit, which involves resection of the head of the proximal phalanx. Both procedures are performed through separate incisions. The surgeon documents the distinct nature of each procedure and the medical necessity for correcting both deformities. For the bunionectomy, a CPT code from the 28292 to 28299 series would be selected based on the specific type of procedure. An Austin bunionectomy, which is a type of distal metatarsal osteotomy, is often reported with CPT code 28296, correction hallux valgus, bunionectomy, with sesamoidectomy when performed, with distal metatarsal osteotomy, any method. Modifier RT, right side, would be appended to indicate the procedure was performed on the right foot, 28296-RT. The hammer toe correction, specifically an arthroplasty of the proximal interphalangeal joint, is typically reported with CPT code 28285, correction hammer toe, for example interphalangeal fusion partial or total phalangectomy. Modifier T1, left foot, second digit, would be incorrect here. Instead, modifier RT would be used along with a toe modifier if required by the payer, or more commonly, the T modifier for the specific toe, for example T6 for the right foot, second digit, 28285-RT-T6 or 28285-T6 if RT is implied by the T modifier for some payers. Because these are two distinct procedures performed on different parts of the foot, first ray versus second digit, through separate incisions, they are often separately reportable. However, NCCI edits must be checked. If an NCCI edit exists between 28296 and 28285, and the procedures are indeed distinct, modifier 59, distinct procedural service, or an X modifier, for example XS, separate structure, might be appended to the hammer toe correction code 28285-59-RT-T6 or 28285-XS-RT-T6, depending on payer guidelines. The operative report must clearly substantiate that the procedures were separate and not integral components of each other. Some payers may apply multiple procedure payment reductions to the secondary procedure. The ICD-10-CM codes would include M20.11, hallux valgus, acquired, right foot, for the bunion. For the hammer toe, a code like M20.41, other hammer toes, acquired, right foot, would be appropriate if it's the second toe. If the hammer toe is specified as rigid, clinical documentation should support this. The operative report must detail the techniques used for both the bunionectomy and the hammer toe correction, including the type of osteotomy, fixation methods, and the specifics of the arthroplasty. This level of detail supports the CPT codes chosen and justifies the medical necessity of the surgical interventions. Accurate coding of such combined procedures ensures fair reimbursement for the surgeon's work and reflects the complexity of addressing multiple deformities in a single surgical setting. Section 8. Complex Coding Scenario 3. Complicated ingrown toenail procedure. A 32-year-old patient presents with a severely painful, infected, and hypertrophied ingrown toenail, onychocryptosis, of the medial border of the left great toe. The patient reports increasing pain, swelling, and purulent drainage for the past week despite home care. On examination, there is significant erythema, edema, granulation tissue, and active purulent discharge. The podiatrist determines that a partial nail avulsion with matricectomy using phenol ablation is necessary due to the chronic, recurrent nature and infection. After obtaining informed consent and administering a digital block, the podiatrist performs the avulsion of the offending nail border and applies phenol to the germinal matrix. A culture of the purulent drainage is obtained and sent to the lab. The primary procedure is the partial nail avulsion with matricectomy. CPT code 11750, avulsion of nail plate, partial or complete, simple, single, is not appropriate here because a matricectomy was performed. The correct code would be CPT 11750, excision of nail and nail matrix, partial or complete, for example, ingrown or deformed nail, for permanent removal. Modifier TA, left foot, great toe, would be appended to 11750 to specify the location, 11750-TA. If only one border of one nail is treated, this code is reported once. If, for instance, both medial and lateral borders of the same nail were treated with matricectomy, some payers might still consider it one unit of 11750, while others might allow reporting with modifier 59 for the second border if it's a truly distinct procedure, though this is less common for a single nail. The diagnostic coding must reflect the complicated nature of the condition. L60.0, ingrown nail, is the basic diagnosis. However, due to the infection and inflammation, additional codes are necessary. L03.032, cellulitis of left toe, or L02.612, cutaneous abscess of left toe, could be appropriate depending on the documented findings of infection. If there's significant granulation tissue, this might be considered part of the inflammatory response to the ingrown nail and infection. The ICD-10-CM code for the ingrown nail, L60.0, should be sequenced first, followed by the code for the infection, for example, L03.032. The documentation must clearly describe the signs of infection, erythema, edema, purulent drainage, warmth, to support the medical necessity for treating an infected ingrown toenail. If a culture was obtained and sent to an outside laboratory, the collection of the specimen by the podiatrist, e.g. using a swab, is typically considered part of the EM service or the procedure itself, and not separately billable. The laboratory would bill for performing the culture, e.g. CPT 87070. If the podiatrist performs an in-office test, such as a gram stain, that could be separately billable with the appropriate CPT code, e.g. 87205. The administration of the digital block anesthesia is also considered integral to the surgical procedure, 11750, and is not separately reported. Comprehensive documentation of the pre-procedure assessment, the detailed steps of the procedure including the matricectomy method, phenol ablation, and the post-procedure care instructions are all crucial for supporting the code's build. Section 9. Conclusion: Upholding excellence in podiatry coding and compliance. Adhering to current podiatry coding guidelines for CPT, ICD-10-CM, and HCPCS Level 2 codes is not merely an administrative task, it is a fundamental component of a compliant and financially sound podiatric practice. Accurate coding ensures that the services provided by podiatrists are correctly represented, leading to appropriate and timely reimbursement from payers. This financial stability allows practices to continue providing high-quality care to patients suffering from a myriad of foot and ankle conditions. Furthermore, precise coding contributes valuable data for health informatics, research, and policymaking, accurately reflecting the prevalence and management of podiatric disorders. The commitment to coding accuracy is therefore an investment in the practice's future and the broader healthcare system. Compliance with regulations, including NCCI edits and Medicare policies such as LCDs and NCDs, is paramount. Failure to adhere to these complex rules can result in claim denials, payment recoupments, and potentially severe penalties during audits by governmental agencies or commercial payers. Ongoing education and training for coders, billers, and even clinical staff are essential to stay abreast of the frequent updates and changes in coding systems and payer requirements. Investing in reliable coding resources, software, and expert consultation can significantly mitigate risks and improve coding accuracy. A proactive approach to compliance, including regular internal audits and reviews of documentation practices, helps identify and correct potential issues before they lead to significant problems for the practice. The detailed coding solutions provided illustrate the complexity involved in translating clinical scenarios into accurate code submissions. Each element, from the selection of the EM level to the application of appropriate modifiers, and the precise choice of diagnosis codes reflecting medical necessity, requires careful consideration and thorough understanding of the governing rules. Podiatry, with its unique blend of medical and surgical services, as well as DMEPOS provision, presents specific coding challenges that demand specialized knowledge. Mastering these intricacies is key to navigating the reimbursement landscape successfully and ethically. This includes ensuring that clinical documentation robustly supports every code submitted on a claim. Ultimately, excellence in podiatry coding and compliance underpins the entire revenue cycle management process. It fosters trust between providers, patients, and payers by ensuring transparency and adherence to established standards. By prioritizing accurate coding, podiatry practices not only safeguard their financial health, but also uphold their professional integrity and contribute to the overall efficiency of the healthcare system. The diligent application of coding principles, driven by a commitment to continuous learning and ethical practice, is indispensable for any podiatry practice striving for long-term success and the best possible outcomes for their patients who depend on their specialized lower extremity care.